I'm Dr. David Song. I'm the Physician Executive Director for Plastic and Reconstructive Surgery and the Integrated Surgical Services here at MedStar Georgetown University Hospital. Patients that I see are folks that have been searching for answers, and they've gone to multiple different ways to find them, and yet most physicians don't know a lot about lymphedema. And so they come with a swollen arm, a hand, a leg, an extremity part that persists even though there's therapy that is available to them, but they're just not in the know about them. Each patient is an individual that is surrounded by family, so we take all that into consideration based on where they're coming from, as many of my patients travel from a far distance. And so we want to know what their support system is, how they got the disease, and tailor that approach to their situation. Lymphedema surgery is relatively new. Within the last decade, it's really taken off. And prior to that, there were just no good answers. And so as a problem solver, as a plastic surgeon, trying to affect the quality of life for some of our patients, we're able to research this area. And this is really what attracted me to surgery for lymphedema. Lymphatic surgery and surgery for lymphedema is really in its infancy. We're just starting to understand the therapies, how and when they're applied, in what combination, who's going to benefit the most, the timing of that surgery. So it's exciting to be on the leading edge of this field. What's satisfying for me is when you've seen a patient at their lowest of lows and you're able to offer them a surgical treatment that then, once they are part of it and they undergo treatment and they're recovered, you see them coming in with a completely different countenance and a completely different outlook on life. Their smile is just radiant. And that challenge of seeing them at their beginning, when in the worst of points of their life, to see them at their best is really what's rewarding. Lymph is a fluid that bathes the cells. So we think about arteries pumping blood to the feet and the fingers, and then veins bringing blood back. The lymphatic system mirrors the venous system, and it is a separate channel that brings back sort of that clear fluid that the cells bathe themselves in. So if you've ever cut yourself shaving and the bleeding stops, there's that clear liquid that continues to ooze out. That's lymph, that's lymphatic fluid. And that solution and that fluid is what needs to drain back into the central system and then get recycled again. Lymph nodes are like the body's first missile detection system that helps to clear and fight off infections. And those lymph nodes also act as little pumps to push that fluid back into the thoracic duct, which then connects to the heart. And so when there's a disruption there, patients can get swelling of the extremity, their fingers, their hands, their arms, feet, knees, legs, even face sometimes. And that's where we can get involved. Lymphedema really comes in two forms. One, the more rare form, is the congenital form. People are either born with it or develop it in their youth. The lymphedema that we treat and that are effective treatment modalities that we have for patients are those that develop lymphedema after lymph nodes are removed or after a cancer operation or a trauma. And those are patients that come in with arms or legs or hands and feet that are persistently swollen and that aren't able to drain. And that can lead to cellulitis or infection, that could lead to a heaviness feeling, that could lead to infections that can be life-threatening. Some may think that lymphedema only affects women or men, but it affects everyone. Anytime lymph nodes are removed and you couple that with potential radiation and obesity, that sets up a patient to develop lymphedema of the leg or the arm. Particularly, let's say you have a patient has their lymph nodes removed in the inguinal region for melanoma or sarcoma, classically in the arm, when patients have breast cancer surgery and lymph nodes removed for that, that's when patients can be prone to develop lymphedema. Well, lymphedema can get worse with time, with obesity. So we know that there's an intrinsic connection between obesity and lymphedema. Some patients that are morbidly obese or very obese can develop lymphedema just spontaneously without having lymph nodes removed. So those two things, along with further trauma and infections, can make lymphedema worse. There's no specific cure for lymphedema. The surgical techniques that we have can really make a dent and mitigate some of the progression and even reverse lymphedema in many, many patients. So some of the surgical options which are intimately tied to physical therapy are lymphovenous bypass. So we're finding the lymphatics in the extremity, whether it's the hand, the forearm, or the leg, and finding that lymphatic channel and rerouting them into the venous system. So finding a local vein and connecting the lymphatic system into the vein using super-microsurgical technique. And when I say super-microsurgical technique, these vessels are less than 1 millimeter in diameter and they're extremely frail. So we're using needle and thread about a quarter of the thickness of your hair under a microscope to connect these lymphatics into the veins to help them drain into the venous system. Lymphovenous bypass, it's an outpatient procedure. Patients take about 2 weeks to recover before they go back to work because we want those connections to heal and become stable. The other option is lymph node transplant. So patients with more advanced disease, we're getting lymph nodes and healthy lymphatic tissue from other parts of the body, be it the back or under the neck or in the groin area, and then transplanting that using microsurgical technique again to the affected extremity. And by moving healthy lymph nodes into the area without damaging where they came from and the limb that they came from, we're able to then replace and or create new pumps and new healthy lymphatic channels to then drain that lymphedema. That recovery is a little bit longer, 3 to 4 weeks. It requires a day or two in the hospital to monitor that lymph node transplant, but patients do quite well from that. And then finally, the other treatment that is an adjunctive measure to lymphovenous bypass and lymph node transplant is debulking, so circumferential liposuction. Liposuction in and of itself doesn't necessarily impact the drainage. It decreases the size and it decreases the scarring of the affected limb and the lymphedematous limb in order to have the lymphovenous bypass and the lymph node transplants work better. The ideal candidate is someone that catches lymphedema early on, after breast cancer surgery, after skin cancer where they've had to remove the lymph nodes in the groin area, and comes to see us before lymphedema really develops. Those are the ideal patients where we can intervene early and make new lymphovenous connections early so that they don't progress on to have progressive and moderate to severe lymphedema. We think so. So we have some protocols here at MedStar Georgetown University Hospital where after lymph nodes are removed, let's say for breast cancer, we're then able to find the lymphatic channels and hook them up preemptively to the venous channels in order to prevent lymphedema. And our early data shows that it's working quite well. And I always say that lymphatic surgery, the success of lymphatic surgery is 50% the surgeon and 50% the patient. And what I mean by that is the patient has to be very diligent with weight loss, with therapy, with continued therapy, with manual lymphatic drainage, with pumps that they use at home. If you combine those two things, then the success rate can be upwards of 90+%, where we're seeing moderate to significant improvement in someone's lymphedema of their arms or their feet and legs. So patients can get involved in therapy, in manual lymphatic drainage and lymphedema therapy before they come to see us. Once they're plugged into therapy, that helps to prime what existing lymphatics are there and healthy to work even more. And of course, weight loss. Weight loss is such a huge part of fixing and treating lymphedema that patients should come to us having been on and been successful with a weight loss plan. When you combine those two things, and then of course stopping smoking and really getting into shape, that really leads to the success of this operation. We at MedStar Georgetown are the leaders in this area. There's not many centers in the Eastern Seaboard, let alone in the entire country, that specialize in surgery for lymphedema. And including myself, I have 4 other partners that do lymphatic surgery. So we are one of, if not the largest group in the country of surgeons that do lymphatic surgery. We've led the way, we're continuing to lead the way, we're pioneering, we are bringing new therapies to fold, and we have the most experience.